and some joining us via video conference. For the benefit of witnesses, I am the Chair, Senator Lydia Thorpe. I am joined today in the room by Senator Louise Pratt. Senator Slade Brockman is joining us remotely. I welcome you all. These are public proceedings being video streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the ground which it is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. Commonwealth officers appearing today are also reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. A copy of the order is available from the Secretariat. I remind committee members and witnesses who are appearing via video conference and who are not speaking to mute their microphones, and remember to unmute when you speak. I now welcome Dr. Jamie DeWitt, who will be joining us today via international video conference from the United States. Dr. DeWitt, as noted in your invitation, parliamentary privilege applies only to people giving evidence in Australia. Parliamentary privilege is a special right that means that you cannot be prosecuted or disadvantaged because of anything you have provided in evidence that has been accepted by the committee or because you gave this evidence. However, because this privilege only applies within Australia, a person outside of Australia will not be protected by parliamentary privilege. As such, you may wish to refrain from making adverse comments about any specific person or entity. For the Hansard record, will you please state your full name and the capacity in which you appear today?
Hi there. Yes, I'm Jamie DeWitt, and I'm serving here as a representative of the scientific community.
Thank you. I now invite you to make a short opening statement, and at the conclusion of any remarks, I will invite members of the committee to ask questions.
Thank you very much. Again, my name is Jamie DeWitt. I'm a professor of environmental and molecular toxicology and director of the Pacific Northwest Center for Translational Environmental Health Research at Oregon State University here in the United States. My laboratory's research program is really dedicated to studying the effects of environmental chemicals on the immune system, and we do study per and polyfluoroalkyl substances, or PFAS, in my laboratory. Our goal is to look at the immune system's overall response to what's known as a challenge, such as how well the immune system makes antibodies to vaccinations and how well different immune cells work. Of my scientific publications, about half of them concern PFAS and include results of research studies that have been conducted in my laboratory at Oregon State and at my previous institution. Other publications on PFAS include reviews or commentaries that concern science-based decision-making for PFAS management. Many of these reviews and commentaries have been co-authored by my fellow members of the Global PFAS Science Panel. This is a group of scientists with expertise in PFAS. Thank you very much for asking me to provide some testimony about my knowledge of PFAS today. I was introduced to PFAS and their effects on the immune system in 2005. I was a postdoctoral trainee at the United States Environmental Protection Agency. Dr. Birnbaum was actually my division director, my boss's boss. When I was a postdoc, I was asked to confirm some findings that had been identified with exposure to perfluorooctanoic acid, or PFOA. These were reports of suppressed vaccine antibody responses in rodents. Now, I call this the vaccine antibody response. We don't actually vaccinate rodents, but for simplicity's sake, I'll just refer to this response as the vaccine antibody response. One of the authors of some of these findings said that PFOA was the most potent immunosuppressant he'd ever observed. We performed several different studies and did confirm that when PFOA is given to rodents in their drinking water for as little as 10 days, they had a suppressed response to vaccinations relative to animals that had not been exposed. Not long after we published our findings in 2008, an epidemiologist published findings reporting that PFOA and other PFAS could suppress the vaccine antibody response in children who are exposed to PFAS in the womb. Since then, there have been many different studies in rodents and different populations of people that have been performed, and the overwhelming majority of these studies have reached the conclusion that exposure to PFOA and other PFAS can suppress the vaccine antibody response. You might be thinking, well, it doesn't really seem like much of a change. It seems mild to moderate, but even mild to moderate immune suppression, such as these studies have demonstrated, can really have profound effects on the health of populations. It can increase the risk of communicable diseases as well as other diseases such as cancer, and the immune system is really a key player in keeping us healthy. When it's impacted, it can lead to lack of health. I wish I could say that the only health effects of PFAS are limited to the immune system, but we call PFAS multi-system toxicants because these agents can impact many different parts of the body. As you probably well know, the list of health effects is growing. Those types of health effects with the strongest body of evidence include kidney and testicular cancer, elevated cholesterol, liver damage, developmental effects such as low birth weight in babies, endocrine disruption such as thyroid disease, and immune suppression. It's been my experience that scientists who do not believe these scientific data are those scientists who work to support continued production of PFAS or lack of remediation of PFAS-contaminated area. There's really only a handful of PFAS that have been studied, but it doesn't appear as if those that have been studied are without at least some risk of producing adverse health outcomes. So what are we supposed to do as a society to reduce burdens? I have a few recommendations. One is that those who consider managing PFAS consider the essential use concept. If the PFAS is not essential for the health, safety, or functioning of society and alternatives are available, its use could be eliminated. Several states in the United States have implemented this approach for phasing out non-essential uses of PFAS. There's also this idea that regulation can support innovation. As you probably know, here in the United States, we now have maximum contaminant levels for several PFAS, including PFOA and PFOS. The goal level for PFOA and PFOS is 0 parts per trillion because they're classified as likely human carcinogens. No person should get exposed to likely human carcinogens in their water. This goal level has inspired many different companies to look for ways to remediate or destroy PFAS. More companies means more competition, means better value for the consumer, and more options for treatment facilities. I think we also need to understand that scientific data for PFAS are still evolving. Many have been understudied with respect to their toxicity, but there's really no reason to continue to allow exposures of these PFAS. Absence of evidence isn't the same as evidence of absence. So why should we as a society wait for people to get sick before we take action to reduce or eliminate exposures or risks? That's my opening statement, and I look forward to your questions. Thank you again for inviting me.
Thank you, Dr. DeWitt. Over to you, Senator Pratt.
Thank you. Thank you for your excellent evidence. Can you tell me the Stockholm Convention, how many of the issues raised in your evidence this morning are addressed by that convention and the amendments?
So my understanding of the Stockholm Convention is that its focus is on persistent organic pollutants or persistent pollutants that have the potential to bioaccumulate and that have the potential or evidence of producing toxicity. Several PFAS are on the Stockholm Convention, including PFOA, PFOS, and I believe PFHXS. So I think the idea behind the Stockholm Convention is that persistence is a driving concern for some of these hazardous chemicals because they're not sustainable in the long term in terms of the health, safety, or functioning of society.
So looking at a regulatory context is how much does, for example, adherence to the Stockholm Convention and implementation of that deal with the issues that you raise in your evidence as far as preventing exposure?
Well, I'm not an expert in the Stockholm Convention, so I appreciate your question. And I belong to a country that unfortunately is not a signatory to the Stockholm Convention.
Okay.
However, my understanding is that when chemicals get placed on the Stockholm Convention, they've already been in production and use and are already present in the environment. And so the goal is to reduce use, eliminate production with the hope of reducing or eliminating exposure and therefore driving down risks that come from those exposures. Yeah. That's my understanding of the goals of the Stockholm Convention.
In the context of the evidence in this inquiry, and I'm probably not as well informed as our chair, but I didn't know that PFAS also had immune suppressant qualities, although I'm sure that in turn also has links to various types of cancers as well. How widely known is that in the way regulators and people think about the need to address PFAS contamination? Has the kind of research you've been participating in high profile enough to really be a driver, and how can we assist in that regard? A driver in mitigation, monitoring and prevention.
So interestingly, several states here in the United States have used the immune system responses as a driver for some of their maximum contaminant levels for drinking water before we had a federal level here in the United States. There's also been pretty good understanding of the risks of immunotoxicity from PFAS in the Netherlands and several European member states. There's been some pretty good studies of scientists across some of those universities that acknowledge the immune system risks. There's also been studies in Sweden, there's been studies in Italy, there's been studies in Denmark, including the Faroe Islands, which is where we've received some of our epidemiological data about the immune risks of PFAS. The US EPA also considered the immune risks in their estimation or their calculation of maximum contaminant levels. However, they ended up using the cancer classification rather than what are known as the non-cancer endpoints, because when cancer classification reaches a certain level, that is the driver for the maximum contaminant level. But in terms of mild to moderate immunosuppression, such as what we see from PFAS being a type of health outcome that is well known, I would have to say yes, but I also interact with quite a few people who are immunotoxicologists, and we've been working very hard to enhance the general public's understanding of immune system risks. And there are people who live in contaminated communities who are very concerned about immune system effects. This was especially prevalent during COVID's peak, and several agencies here in the United States came out with statements of concern on immune system health for communities of PFAS contamination.
So in that context, there need to be a greater impetus for immunisation and surveillance to ensure levels of immunisation are high in PFAS contaminated communities so that we can get as much herd immunity as we can, and what's the scientific relationship there? I believe in universal immunisation anyway, but what does that add to our understanding of immunisation strategies?
Well, certainly immunizations give the immune system a tool to fight off potential pathogens. And without having that tool, it would be like trying to build a house without a hammer, maybe just a few rocks, instead of a hammer that's going to be very precise in helping you to build that house. I do know that there are concerns about diminished vaccine antibody responses in communities where PFAS contamination is high. There is some, I think, work on the clinical side to ensure that people who live in these communities can have conversations with their healthcare providers for additional or follow-up vaccinations should they not generate appropriate responses to vaccines. This is a recommendation that has been, I think, challenging for some organizations to make, because if somebody doesn't respond appropriately to a vaccine, we often don't know because we don't follow up on antibody levels except for certain types of vaccines. But I think there is an increased awareness that patients need to have these conversations with healthcare providers to make sure that they are properly protected when they get vaccinated.
So if we're not doing that kind of surveillance in Australia, how should and could we be doing that? To really monitor, because there's been a lot of debate around cancer and PFAS in communities that might have elevated levels of exposure, and all the focus seems to have been on cancer, but having a more in-depth look at immunisation and immune responses, as well as, it's not recommended to do blood tests for PFAS according to the Cancer Council, but you could also look for immune responses, etc.
Yes, I think that would go along with PFAS blood testing in areas where there is known PFAS contamination, probably for the general population.
You would support blood testing for PFAS contamination on cancer grounds as well?
On the grounds of several different health effects.
Yeah.
In 2022, the Agency for Toxic Substances and Disease Registry here in the United States issued a report on clinical guidance for PFAS-contaminated communities, and the recommendation was blood testing for people who have elevated risk of exposure for PFAS. And with the results of those blood tests, there were recommendations for what clinicians could do to elevate standards of care for people with elevated levels of the PFAS that they included in their report, which included PFOA, PFOS, and I believe 5 other PFAS.
So currently, for example, the Australian Cancer Council has repeated the evidence from healthcare sectors, and they say testing PFAS levels in the blood is not recommended, even for, I think, communities who have exposure, as it has no current value in informing clinical management. How should we address a statement like that as a committee in terms of reflecting that back at, the different medical organisations that, define clinical standards around these things and why, and then also the relevance of that to research?
So that is contrary to the recommendation of the report that I just mentioned. This is the PFAS clinical guidance report from the Agency for Toxic Substances and Disease Registry.
Right.
I think patients have a right to know about levels of PFAS and other contaminants in their blood.
Yeah.
And when they have that knowledge, they can then be armed with that knowledge to take to their healthcare provider. They could even say, this report recommends that I get additional breast cancer screening or additional testicular cancer screening or have my liver serum enzymes measured more frequently. There's a woman here in the United States who worked with a healthcare provider because she lived in a contaminated community, who availed himself of information and said, you know what, let's do some of these additional tests because you do have very high levels of PFAS in your blood. They discovered that she had thyroid cancer, and if he hadn't taken action to do some additional blood work on her, they wouldn't have found the thyroid cancer until it was much more progressed. This is an example of just one individual, but it is an example of an individual who was proactive with her healthcare provider. And I think all people should have the opportunity to have that type of elevated care if they do have elevated levels of exposure.
Thank you. I've certainly got more questions, Chair, but I'm happy to rotate.
Thank you.
Call back.
Thank you, Senator Pratt. I've got a few questions. And I think we've also got Dr. Birnbaum coming in at some stage. So if Dr. Birnbaum comes in, then we'll avail some of those questions to her as well. Every Australian, and no doubt many or all people in the US, have PFAS in their blood. What does the available research say about the long-term effects of low-dose persistent exposure?
I believe that most of the health studies that have been conducted in exposed human populations do represent that type of exposure, this long-term or chronic low level of exposure. The people who are at elevated risk tend to be those who have greater levels of certain PFAS in their blood, but the health effects that they experience, to the best of my knowledge of the epidemiological studies that have been conducted, are from that chronic low-level exposure. Now, there can be differences based on other factors in people's lives that could influence how they respond to the PFAS. There could be factors related to people's sex or age or genetic predisposition, but the evidence demonstrates that these health outcomes do occur at very low levels of chronic exposure.
Thank you. So what are effective ways to treat and support people who are already dealing with high PFAS blood levels due to their exposure, and hopefully avoid or reduce resulting health impacts?
Yeah, I think people in your country were some of the first to demonstrate that one of the ways for reducing PFAS blood levels is to donate blood. I believe there have been some firefighter studies in Australia that have demonstrated the efficacy of this particular approach. There are some drug trials with an agent known as cholestyramine, which can help to reduce PFAS uptake and also may help to reduce PFAS blood levels. Those are still, I think, fairly early studies. There have been a couple of publications on this particular agent. But right now, the only known way for reducing PFAS in your blood is time and reduced exposure so that you don't continue to bioaccumulate PFAS into your body.
The Australian government and industry often say the evidence is inconclusive or inconsistent and use this as an excuse to delay or avoid action. We have a PFAS, a cancer cluster in an Aboriginal community called Wreck Bay who aren't provided with any kind of blood testing. They're still drinking dirty water, still bathing in dirty water, and they have still a number of cancers from children to elders in that community. And that's the feedback we're getting from the government. So from your perspective, how robust is the evidence base, and how should regulators treat uncertainty when dealing with persistent chemicals?
My appreciation of the scientific literature comes from my work with PFAS as a scientist. And with respect to some of the health outcomes, the level of uncertainty is actually quite low if you look at consistency across studies, and if you look at the data that are supportive from experimental animal studies. For example, in 2023, a study was published on just the epidemiological findings for PFAS. It was a systematic review and meta-analysis. So it looked at 5 different PFAS, and it looked at antibody responses across different vaccines in adults and in children. And what they found is that the results of these different studies were actually very homogeneous or consistent. There was agreement among the studies, even across different types of vaccines, that these PFAS were all able to reduce the response to vaccines and that children were more sensitive. If we look at some of the studies related to cholesterol elevation, we also see consistency across studies. If we look at the studies related to decreased birth weight, we could see consistency across studies. So there may be differences in terms of the magnitude of the outcome, but what we see is that there's still reductions in birth weight, there's reductions in antibody responses, there's elevations in cholesterol. And there was also an interesting paper published several years ago by some of my colleagues that said, if we look at the differences in the regulatory standards across states here in the United States, the differences in the standards weren't necessarily based on uncertainty in the science. The differences in the standards were based on social and political drivers in those individual states. So that social political context led to differences in standards, not disagreement about the certainty or uncertainty of the science.
Thank you. Well, we certainly had 3M hanging around Parliament House when this inquiry first came out. So they were very quick to get into Canberra and make some friends. So why is it scientifically valid or even necessary to regulate PFAS as a class rather than chemical by chemical?
I was part of a scientific publication that came out a couple of years ago that did recommend a class-based management approach for PFAS, and it was based on shared characteristics of concern. One of the characteristics of concern is persistence. One of the characteristics is bioaccumulation potential. One of the characteristics is mobility, so the ability to move to points distant from a point of emission. And one of the characteristics of concern was toxicity. As a scientific group, we agreed that not all PFAS had all of these characteristics, but all PFAS had at least one of these characteristics, and all PFAS can be defined with a single chemical definition. Therefore, chemically managing them as a class seemed to make the most sense to us as a group as we considered this publication.
Thank you. So, in your view, which jurisdictions are currently leading on PFAS regulation globally, and what sets them apart, and how should this country be responding?
I can speak about the United States, and there are some states here that have implemented, as I mentioned in my opening testimony, the essential use concept. The state of Maine has implemented a phased process for eliminating non-essential uses of PFAS. I believe that they're phasing out these uses by 2030. The state of California has implemented the approach. The state of Minnesota has implemented the approach. And several other states have identified product use categories that they've determined to be non-essential uses for PFAS. The European Union is considering a PFAS restriction, and while it's not exclusively based on the essential use concept, it does use the concept as a way to determine what PFAS may be allowable under the restriction and what PFAS may be excluded under the restriction, or may be phased out under the restriction, I should say. So I would say there are individual states here in the U.S., and then there are actions in the European Union, and those are what I would define as some of the leaders in terms of taking action to phase out PFAS.
Senator Pratt, did you have some more questions?
I certainly do. I'm just looking at the Health Department's website here in Australia, health.gov.au on PFAS, and I was just trying to unpack the kind of level of there's kind of statements that say we don't have as much of a problem here in Australia as other places compared to how you frame the issues. And so they go on, they say there's limited evidence of human disease or other clinically significant harm resulting from PFAS exposure. Some studies have found associations between people exposed to specific PFAS chemicals and the following effects. And it does go through immune system, thyroid, lower birth weight, menstruation, increased cholesterol and uric acid, and an increased risk of testicular and kidney cancer with a couple of the PFASs. But they say that most of this evidence relates to PFOA, the specific type that's less common in Australia, and that they're typically from areas where chemicals like PFOA are manufactured and exposure levels are higher than in Australia. So, we still get our regulators and those responsible saying they're being precautionary, but framing it in the, you can hear how it's been framed to kind of mitigate, it's not actually mitigating the problem, it's saying that, explaining the problem in that kind of the way they've framed it. What do you make of, is that a contemporary, scientifically relevant statement to give the public? How would you critique it?
I was a co-author on a publication with a retired medical doctor from West Virginia University named Alan Ducketman. He found that public health messaging regarding PFAS was not really helpful across many different agencies and across many different countries. So when we wrote the paper, we didn't pick just on the United States, we picked on other countries as well. And I think there's a balance between creating something that may inspire fear versus creating something that may inspire people to be proactive about their own health. And I'm not a clinician, I don't know what that balance is, but I know when I talk to people about my experiences and knowledge as a scientist, I want people to be armed with information so that they can make decisions in the best interest of their health and the health of their families. And discounting scientific evidence, in my opinion, isn't helpful. Just because there is not a causative link between PFOA or PFOS or PFHSS exposure and a disease, we still have very strong evidence about those links from epidemiological studies with support from experimental animal studies. So that means that the biological plausibility of these effects occurring in people being from PFAS exposure is increased. So I would say it's better to arm people with knowledge so that they can take action rather than arming them with information that may lead them to have no concerns whatsoever.
Why do you think we're still getting agencies and organisations referring to there not being a statistically significant link between PFAS and cancer? Is it because they're comparing it to only high exposure sites, and therefore they're discounting and ruling out those reports? How should we encourage our regulators to look at the evidence?
Well, I have two answers to that. And one, I teach statistics, and so when I hear statistical significance, I think, well, that's not the only reason for making a decision, because sometimes statistical significance can be inaccurate. So it's important to look at the body of evidence, including results that are and are not statistically significant, and look for those results that also have biological meaning in the absence of statistical significance. So that's, kind of a weight of evidence approach. My second response to that is that my understanding is that it can be very challenging to uncover causative links between diseases and exposure when you're dealing with an environmental contaminant. I go to the doctor and I take a drug if I have an illness. I get that drug in a precise dose. I take it for a specific amount of time. We even, probably even know where it was formulated. So it's very easy to track disease with drugs that people take because we have that type of information. It's more challenging with epidemiological studies. But I think if you look at different epidemiological studies, include the experimental animal studies, that the evidence overwhelmingly supports that PFAS are hazards, and exposure to PFAS increases the risk of experiencing those hazards.
Thank you, Chair.
Thank you, Senator Pratt. I'll ask a few more questions if that's okay. In Australia, as in other parts of the world, chemical companies are often the only source of toxicity data. How does this affect the quality and independence of the science used to assess human health risks? And how big a role does industry-funded research play in skewing regulatory outcomes?
I should preface my answer by saying that I do serve as a plaintiff's expert witness in cases involving PFAS, so I do work on the plaintiff's side in such cases, and many of these cases, the defending party are members of the chemical industry. So I think that toxicity studies conducted by industry are well-conducted studies. They often hire contract research labs. They produce copious amounts of data. They often follow guidelines. And so I think quality-wise, the studies are very good. However, many of the guideline studies that are performed don't always ask the right questions. For example, I studied the immune system, and immunotoxicity isn't a required study unless there's a finding of effects on lymphoid organs. These are the spleen and the thymus. So if there are changes in the cell structure or changes in the size of those organs, that's a flag for doing an immunotoxicity study. But for example, with PFOA, we see effects on the immune system in terms of the antibody response in the absence of any effects on the spleen or thymus weight. So if we just use spleen or thymus weight as an indicator, we wouldn't call PFOA or PFOS immunotoxicants, because we would never have uncovered the antibody responses. Hopefully that all makes sense.
Yes, thank you. The US EPA has recently invested heavily in PFAS risk assessment and has adopted far stricter exposure limits. What can Australia learn from their process and methodology?
I should also add that I was a member of the PFAS Science Advisory Board. This was a group of scientists that were advisory to the US EPA as they were considering their maximum contaminant levels and maximum contaminant level goals. Our job was to give the agency advice on whether or not the scientific approach they were using was appropriate and whether or not their conclusions were based on appropriate or sound science, to grab that phrase. The US EPA's maximum contaminant levels for PFOA, PFOS, Gen X, PFHXS, PFBS, and PFNA are based on strong scientific evidence that has been reviewed internally and externally. The MCLG, or the maximum contaminant level goal, as I mentioned, for PFOA and PFOS is 0 parts per trillion in drinking water because of their classification as likely human carcinogens. For the other compounds, the non-cancer endpoints are the drivers. These include effects on the thyroid gland, on birth weight, and on the liver. And some of the effects are in rodents. Some of the effects have been observed in epidemiological studies. And so I believe that the US EPA evaluated the database to the best of their ability and evaluated the science and reached these conclusions appropriately.
Thank you. I just have two final questions, and I'll put the rest on notice because I could sit here all day asking you questions. Australia is reviewing its water guidelines and contracted a private consultancy to do the assessment, a consultancy that has ties to the PFAS industry. Are you aware of other countries where this has occurred, and what risks do you think this poses?
I'm not specifically aware of other countries that have engaged consultants who have ties to industry, but I understand that in many different countries, scientists from industry and representatives from industry do have a right to contribute to the risk assessment process and to the rulemaking process. They have the right to submit comments. They have the right to have a response to comments. I think this is a good way forward to establishing regulatory limits that are protective for people who are unwillingly exposed, but still allow for economic development or innovation with respect to chemical production. I think it's important that regulatory approaches should have a balance, though, of voices from different sectors and shouldn't necessarily be driven by voices entirely from one sector.
Thank you. And my final question is, in your view, what are the most urgent reforms needed internationally to ensure that chemical regulation prioritises human health and environmental safety over commercial interests?
It's interesting you should ask that, because next week and the week after I'll be speaking at two different conferences related to green chemistry and sustainable chemistry. And I believe that I've been asked as a toxicologist to talk to chemists because toxicology isn't necessarily part of the chemical development process. And there's an interest in those in the green chemistry or sustainable chemistry arena to start thinking about toxicology before the chemical makes it to market rather than after it's already led to contamination in the environment. And so I think it is very important for chemical developers to consider toxicity at the very beginning of the process and start to incorporate some of those toxicological approaches in the chemical development process.
Thank you very much. I see that Dr. Birnbaum has joined us, so we might ask the remaining of questions to Dr. Birnbaum. So please feel free to stay on the line, Dr. DeWitt. Dr. Birnbaum, thank you very much for joining. Do you have an opening statement? We can't hear you. Looks like the line is quite sketchy. No, we can't hear you. Are you on mute?
She can hear us.
Maybe raise your hand if you can hear us. Yep. Okay, we just can't hear you. I think we'll take a short break. Yeah, we're having trouble hearing you, Doctor.
Usually it's because you have to choose the right microphone in two different places on your computer. Usually you have to choose the right microphone in two different places on your computer. I see that you're wearing an Apple headset. Are you on an a tablet or phone or on a computer? Okay. Anyway, we can't hear you, but usually having connected to these things, you just need to make sure that in the app that you're using to log on or in the web browser, you've chosen the right microphone. Hopefully that helps. No?
Okay, we might just suspend proceedings and we'll try and get you on the line in the background. So we'll take a 10-minute break.
Yeah, we can call you, have you on the phone at the same time as seeing your face.